Namaste, everyone. Those of you who don't know me, my name is Madhu, and I have the pleasure of introducing to you today a consultant urological surgeon who is from Manchester Foundation Trust, which is within Shaw and Manchester Royal, which is combined now. Dr. Ravi Pillai, Ravi Shankar Gopal Kumar Pillai, very, very warm welcome. Thank you so much for volunteering and supporting our event. Very warm welcome. Over to you, Dr. Pillai.
Thank you very much. Thank you for having me today. So I'm going to talk about prostate and prostate cancer problem. Okay, so let me start. So basically, prostate is a walnut-sized gland which is present just underneath our bladder, and the urine tube passes through the prostate gland like a tube passing through an apple core. You can see the urine accumulated here. It goes out through the prostate like this. And the role of prostate in human body is to produce around 30% of the semen fluid. And the role is to keep it liquefied so that the sperms can easily mobilize and fertilize. So it's a reproductive organ. There are three main problems which happen to the prostate gland as a part of aging process. One is a benign prostate enlargement. Second is prostatitis, which is an infection of the prostate, or prostate cancer. In benign prostate enlargement, it is like normal tissues increasing in number and causing an enlargement of the prostate gland, thereby making the channel blocked, as you see here, so that there can be difficulty in passing urine. This is benign, and which is a part of aging, and it happens in 50% of the people by 50 years of age and 70% of the people by 70 years of age. Not all patients will have problems related to this, but a part of the patients may present with symptoms. Others, even though they have enlargement, it may not be completely blocked and may not produce any symptoms. The prostatitis or prostate infection, just like any other organ in the body, prostate also can get infected as a part of urinary infection. So that is usually treated by an antibiotic. If we go to the prostate cancer specific, just like any organ in the body, there's a balance between cell growth and cell death. When there's an abnormality in this balance, the abnormal cells grow excessively in number. The difference between a benign growth and a prostate cancer is that benign growth increase in normal cells, while in prostate cancer there's an increase in abnormal cells. The problem with abnormal cells, it can invade tissues, it can invade blood vessels, it can invade and cause harm. It can spread locally, or it can spread to other parts of the body via blood vessels or lymph vessels. So why prostate cancer is so important is that prostate cancer is the most common cancer in men, and it is the second most common cause of death after lung cancer. I don't know whether you really know that 47,500 people are diagnosed with prostate cancer every year. And in one particular year, more than 10,000 people die, which means 30 every day and one every 45 minutes. The good thing is that in 1970, around 40% of the people only survived beyond 5 years, while with the new technology and medications and treatment, more than 80% of the people are surviving more than 5 years. I've brought you a population, a cross section of a population in UK. There's a reason behind that. As you know, 87% of the people in UK are whites, and 7% Asians, and 3% blacks. The reason why I brought this picture is because cancer is inherently a racist cancer. Why? Because when 1 in 24% has a lifetime risk of prostate cancer death in white people, the Asians have only 1 in 44 and black 1 in 12, which means prostate cancer according to the prostate cancer incident rate in England, black men are more likely than Asians or white people to get prostate cancer. Or let me just, the black men are 2 to 3 times more likely to be diagnosed with prostate cancer compared to the white men of the same age, irrespective of the access to medical facility. Asians are lowest in the rank in that terms. We are lucky that we are not that much prone to prostate cancer. Age wise, if you want to know, the most common presentation is between 70 to 75 years age, but we have seen as young as 40 years of age to as old as 100 years of age. The important risk factors of prostate cancer are family history, which means if you have a father or brother diagnosed with prostate cancer, especially younger age group like 60 years of or younger, then the chance of you having a prostate cancer is much higher, 3 to 4 times. So those patients need special attention and special investigations. Some studies shows that a mother with breast cancer can have an inheritance of a faulty gene called BRCA2 gene, which makes it highly vulnerable to have prostate cancer. So that also is considered to be a risk factor. As I have already mentioned, the black Africans have 2 to 3 times more risky to have prostate cancer. There are specific reasons why I differentiate into each of this group. You will understand that in the coming slides. While we look into all the data, obesity is also known to be a risk factor for prostate cancer. So uh, these all risk factors are taken into consideration when we address the prostate cancer. As you might have heard about screening for various cancers. Screening means is basically finding the disease when they are not causing any symptoms of signs. You might have heard about breast cancer screening, colon cancer screening. Prostate cancer screening was also extensively studied. The two common modalities we use for prostate cancer screening were one blood test called PSA or prostate specific antigen and a prostate examination through the back passage called digital rectal examination. The PSA is a blood test. It is actually produced in the prostate. The problem with the PSA is that it is specific to the prostate gland, but it's not specific to the cancer. So it can be increased in infection, it can be increased in benign enlargement, it can increase in cycling, vigorous exercise, as well as cancers. So all elevated blood tests of PSA is not indicative of a prostate cancer. So the prostate cancer screening is not considered to be a big success because the PSA is not prostate specific. It is it's prostate specific, not cancer specific. The pickup rate of PS through of prostate cancer through PSA is low. As you know, if you know the terminology, sensitivity and specificity, you know that it's 80 and 40. You should know that 15% of the men who are having normal PSA tests may have prostate cancer, and 2 of them may be having high grade cancer. And 75% of the men with a positive PSA test, when they go to have a biopsy, there won't be any cancer. So the PSA test and the prostate examination is not accurate. It can be an unnecessary investigation leading to false positive and excessive investigation. It can lead patients to have unnecessary investigation as well as unnecessary excessive treatments, which can cause lots of side effects. So there were extensive studies in Europe as well as US, which showed that screening of prostate cancer did not did not reduce the death of the patients, and hence prostate cancer screening is not adopted in UK especially, or in most of the developed nations. Prostate cancer screening is not done. Then the question will happen, when should I offer a PSA testing for prostate cancer? What should I do? So the NICE guidelines, which is the National Excellence Guidelines in UK, which is the all of the medics follow, says that anybody over 50 years of age coming to a GP requesting for a PSA test for various reasons should be explained about the risk of PSA, that, oh, this is 15% like this and 75% biopsy will be negative. And you, if it turns out to be positive, you'll have biopsy and various treatment, which may be a little bit excess. And there's no difference in mortality by doing this. And if the patient still would prefer to have it done, you can offer him. Otherwise, PSA is only offered to PSA, and the prostate examination can be offered to patient with a specific symptoms related to the urinary tract. For example, nighttime urination, excessive nighttime urination, increased frequency of urination, hesitancy to start urination, urgency, frequency, retention of urine, erectile dysfunction, or also known as impotence, blood in urine, unexplained symptoms of metastatic prostate cancer like sudden onset back pain, paralysis, things like that. So if these patients turn up to a GP, the GP will offer a PSA blood test and a prostate examination. And if it's abnormal, he or she will refer to a specialist like us. And many people may have, what is the PSA? Because many might have had this test done. Historically, we were thinking that we were just put a arbitrary value like 0 to 4, which is no more the case. Currently, we have accepted a standard. Again, this is an arbitrary value. We have accepted a standard. Anybody coming from between 50 to 69 of years age, we will do one PSA. And if the PSA is above 3, he'll be referred to a specialist for further investigation, and that too in a highly suspected cancer pathway. That means within 2 weeks' time, we will be seeing this patient in our specialist clinic and offering other investigation, which I'm going to talk about. If the patient is above 70 years of age, then this 3 value is no more valid. Then we actually we can follow a value of 6.5 and above. The reason being that if the PSA is below 6.5, there is a very low chance that this patient can have a significant prostate cancer to kill him or cause damage to him in the next 10 years time, which is the life expectancy of an average UK adult. Other modalities which we sometimes use to assess the PSA is called PSA velocity. Instead of depending on just one reading, we we measure PSAs on a serial measure and see the annual increase in PSA. And if it is about 0.75 increase, we accept it as suspicious and do further investigation. Or more specific, a PSA density, which is again not important to a layman, but for a medic, if you do an MRI scan, if you have the volume of the prostate and the PSA, we divide to find out PSA density, and if it's above 0.15 nanogram per ml, we consider it to be significant and offer further investigation. Prostate examination is done by a finger examination through the back passage, because as you see that this is the easiest and only way to touch a prostate. The problem with this is highly inaccurate and operator dependent. I may suspect a prostate cancer in one person, and a other person may say that no. Third person may be totally different. High grade cancer and high stage cancers most of the time are accurate, but the lower the stage of the cancer, the higher the inaccuracy. So we can't screen or depend on just prostate examination for screening purpose. The current pathway for any prostate cancer patient or suspected prostate cancer patient reaching our hospital in a specialized center is to have an MRI scan. Irrespective of any patient coming with a suspected prostate cancer will have MRI scan in the current scenario. And still, it's not 100%. Around 10 to 25% of the patients, low risk scans can miss the prostate cancer. So the only advantage is that at least high risk prostate cancer will be detected. If it's a low risk prostate cancer, and if even if you miss it, it's unlikely that it may damage the patient, or by serial measurements over the period of time we may be able to pick it up. So once we do an MRI scan, if MRI scan is suspicious, if the PSA is suspicious and prostate examination or any of this is suspicious, we go ahead with something called a prostate biopsy. Again, historically, prostate biopsies were done just like the prostate examination, through the anal passage, by passing an ultrasound probe and taking biopsies. But nowadays, we are doing it or some other manner which called transperineal. Instead of going through this through the anal passage, we can pass through the skin between the anal passage and the scrotum and take the biopsy with similar benefit and less risk of infection. So when we do a prostate biopsy, we can get a definitive diagnosis of a prostate cancer. The histopathologist will see under the microscope and grade the prostate cancer or divide the prostate cancer into different groups. We call it low, moderate, and severe grade. Many patients who are exposed to prostate cancer may know about this scoring system which is used in prostate cancer. It's called Gleason score. So the scoring range between 2 to 6, which is low grade, 7, which is considered moderate, and 8 and more considered to be severe grade. uh, this may be a bit jargon for you, but some of you who have come across prostate cancer may be very closely associated with these numbers. So the prostate biopsy, is it simple? Yes, it's a simple procedure, but still there is a small 1 to 2% risk of sepsis, which has dropped down to less than 1% because of this transperineal biopsy. As you can see here, small amount of patients complains about some discomfort and pain. Most of the patients tolerate that well. Most common bothersome problems are blood in urine, blood in semen, blood in back passage. But invariably, majority of the patients settle over the period of time. So very few patients during the prostate biopsy say that, oh, I can't tolerate, because this is done under local anesthesia and most of the patients tolerate well. If they cannot tolerate, we do it under general anesthesia when the patient is asleep. So the stages of the prostate cancer. So I'm not going to the detailed staging, but for your understanding purpose, I will say that the prostate cancer, when it is within the within the prostate gland without invading any outside tissues, we call it localized prostate cancer. And if the prostate cancer just breaks out the outer capsule or the covering of the prostate and goes out, we call it locally advanced. Or if it spreads through the blood vessels or lymph to the distant parts like lymph nodes, bones, other body parts, liver, lung, brain, we can call it metastatic disease, just like any other cancer. So we use MRI scan to diagnose the prostate cancer nowadays. As I told you, it's almost 75% accurate. And when in this MRI scan, we can see an abnormal area. And the advantage, one, we can find the suspected area. Second, it can guide us to biopsy the suspected area rather than just blindly biopsying the whole prostate. So the improvement in including the MRI scan into the prostate investigation is actually a groundbreaking change in prostate cancer pathway. In suspected patients with metastatic disease, one of the common investigation we do is called a bone scan. It's a nuclear bone scan. We have a special injection and then do a scan which can show whether the cancer has spread into the bones. Occasionally, we may also use CT scan to see whether other organs like liver, brain, lungs, or these things are involved. But most commonly, the metastatic spread of prostate cancer is to the bone. That is why we are using the bone scan. So, as I told you, whenever we get a prostate cancer, we do this investigation. Then, as a specialist, our job is to stratify the patient according to the risk. The patient's risk can be divided into low, intermediate, or high. Three factors play in this role. One is the blood test or the PSA. We know that it's not very good for screening purpose, but for treatment purpose, it's really good. That's why we are using it for risk stratification. We use PSA, the histopathological scoring, which I've mentioned about Gleason score, and the stage of disease in the MRI scan or a clinical examination. And we divide into low risk, intermediate risk, and high risk. And why we do this? These are the treatment options we provide to the patient with prostate cancer, and the treatment options are provided according to their risk. I will just briefly tell about the types of treatment options we give. One is called active surveillance. Active surveillance means we are closely monitoring, actively monitoring the patients to make sure that the patient's cancer is not increasing or is causing problem to the patient. That's called active surveillance. Second is a surgical treatment whereby we remove the entire prostate. Third, I'll go into a bit more detail in the later slides. Third is called radiotherapy. High intensity X-rays are used to kill cancer cells within the prostate in this modality. Fourth one is called hormonal treatment. In this treatment, we suppress the testosterone hormone in a male, which is the causative factor for the prostate cancer to progress. So these are broadly the treatment options, and I will go into each of them in the coming slides. So active surveillance in low-grade prostate cancer, there was extensive study. They have given all the options to the patients, like just watching and waiting, just a surgical treatment, and uh, radiotherapy. And they found, in the coming slide you will know about that, they found out that there's no difference in outcome, any of these modalities. That's why active surveillance is so important in a low risk prostate cancer. This is usually given for localized cancer. That means low risk. The cancer is within the prostate gland. Second, the cancer is low grade under the microscope by a histopathologist. It is small in volume. The PSA is low, just like to say less than 10. And in such patients, instead of doing any treatment, we just every 3 months we repeat the PSA test and prostate examination. And at the end of 1 year, we just repeat an MRI scan to see whether there is any change. If there is any change, we offer a prostate biopsy to see whether any change in the grade of the cancer. If there's no change, we carry on with watch and wait, actively monitoring and watch and wait policy. This is called active surveillance. So why active surveillance is a very good option? If you see, this is the study which compared all the three modalities: active surveillance in the first one, surgery in the second one, radiotherapy in the next one. When they looked at after 10 years, they grouped, imagine they grouped 100 patients in each group, and at 10 years of time they've just checked, oh, how many of them are alive. Surprisingly, all the all the three groups, 98% of the people were alive. So is surgery or radiotherapy making any difference in terms of survival? No. Then they checked whether the disease is progressing. Yes, the disease was progressing. In active surveillance, or just watching and monitoring patients, around 20% of the patient, the disease was progressing, either progressing locally or histopathologically or spreading to other part, but still they were all surviving. While in the treated group, like a surgery or radiotherapy, around 8% of the people, they progressed. So there's a big difference in progression, but it's not making any difference in survival. So imagine there is a 70-year-old man, we are treating we are offering all the three options, and at 8 years of age he is alive even after any of these treatment modalities is not making any difference. Then what about the other treatment, surgery and radiotherapy? You can see that the surgery at 6 years, like short term, like 3 months, 6 months period, surgery and radiotherapy have its own complications, like urinary, I'll talk about that later, but urinary incontinence, erectile dysfunction, urine problem. In radiotherapy, bowel problem, bladder problem, these all problems are there. But when we looked at 6 years time, it was no much different from an active surveillance group, surprisingly. So, uh, in a if we want to avoid that, even that short-term discomfort caused by the side effect of all this treatment, and in a low-risk patient, active surveillance, just keeping a watch and keep watch an eye on the patient's cancer is good enough, like any other treatment. So, in patients with high-risk disease, which is again within the prostate gland, if we just watch and wait, he will progress and die. So we have one option of treatment is called prostatectomy, or doing a surgery and removing the prostate. You can see here that the prostate, as I've mentioned, your prostate is a gland just underneath the bladder. And in radical prostate surgery, by curative surgery, we remove the entire prostate gland and the seminal vesicles, which is again a sac which produce a part of the semen. We remove these both organs out and connect the tube directly to the bladder, like you see here, so that there's no more prostate and the tube is directly attached to the bladder. So this, the prostate is out. So majority of the patients do well. So there's no more cancer unless uh, microscopically there was some cancer which was outside and we remove, and there can be some leftover cancer there which can later progress and be problematic. But 80% of the patients do well. Okay, and this can be done in high grade cancer, which is well within the prostate. Even in a low or moderate grade prostate cancer patient, you can offer this if they don't want to take the active surveillance or just watch and wait route. So any patient with localized cancer who would prefer to have removal of the prostate, psychologically some patients have the cancer out of the body, and they are ready to accept complications of this procedure, like erectile dysfunction, uh, urinary incontinence, small percentage of risk complications immediate post-operative period, like any surgical treatment. Those patients may accept this and proceed. So this procedure nowadays is done by a robotic manner. Many patients are afraid when they say robot. When we say robotic surgery, it's not done by a robot, but it's robotically assisted. The surgeon do the operation in a console, and the robot do the motion inside the patient, do the surgery. The advantage of this is that abnormal movements, like if I just move my hand abnormally because of a fly moving around, it won't move. There's some logic and artificial intelligence in the whole system. So the routine movement which I make to do the surgery is only accepted, and any unwanted movements are not there. And our just like our hands, there are 7 degrees of movements which our hands, same way our hands can move, the robot's hands can move inside our body, so that we can do it well. It's a 3D vision we get. Just like I put my head inside the body and do the operation, the surgeon with the get the same feeling as we do the surgery. So these are all the advantages of a robotic radical prostatectomy, or a robot assisted prostate surgery. The side effects of this surgery, the short term, most of the patients will have some form of urinary incontinence because the prostate is gone. We are attaching a tube. The muscles and all sphincters will need some time to rehabilitate and get back to normal. So majority of the patient will have some sort of short-term urinary incontinence, but most of this thing will settle by 6 months time. But 3 to 5% of the patients will have urinary incontinence who may need further treatment, like further surgery or things like that. Most of the surgeons offer the patient some pelvic floor exercises which show tremendous improvement in rehabilitation of the patient's post surgery. So they do some pelvic floor muscle training before the surgery, so that after the surgery the recovery is faster, they can carry on doing the pelvic floor muscle and improve. Erectile dysfunction, all the nerves which cause the erection passes just by the side of the prostate gland. Invariably, any good prostate surgery, you will lose those nerves, and erectile dysfunction is almost 80 to 85% unavoidable. Some newer techniques whereby in selected prostate cancer, where the prostate cancer is well deep within the gland and the outside capsule is far away from the cancer, and if it's safe to uh, spare that nerve and operate the prostate alone, it's possible by doing that in improving the erection, improving the quality of erection, or you can say to avoid the erectile dysfunction is possible. But these are done only in selected patients, but it is possible. Radiotherapy is an alternative methodology. It's again, when you look broadly, all are having equal benefits. The patient choice is dependent usually on the uh, complications the patient will decide, or the psychology of the patient. In again, locally advanced as well as localized cancer, high intensity x-rays are used to kill the cancer within the prostate cell. So we don't remove the prostate, but we just uh, uh, we shoot the prostate cancer with a high intensity x-ray and kill the cancer. While in surgery, the patient is admitted for hospital in the hospital, and patient may stay in the hospital for a week. uh, for a week, these patients every day, for half an hour, stay in the hospital, have this radiation 5 out of 7 days a week for 4 weeks, and go home. That's a usual pathway. And in high risk patients, studies show that, and hormone injection, which I'm going to explain in coming time, hormone injections along with the radiotherapy is giving an added benefit. So most of the high grade disease patients will have hormones as well as prostate radiotherapy for somewhat 3 to 6 months before the surgery, up to almost 2 years after the surgery. After the radiotherapy. An alternate form of radiotherapy is called brachytherapy. Again, this is done only in specific cases, whereby the X-ray beam emitting small seeds are placed into the prostate, so that these beams will kill the cancer cells in the prostate. Very small gland, small volume cancer, low grade. In some centers, these are offered. In specific group of patients, these are beneficial or equal to other modalities, but very few centers do it. Some centers do a combination of brachytherapy, which the seeds which are placed in the prostate, along with external radiotherapy. So radiotherapy, brachytherapy, brachytherapy plus radiotherapy. But in general, these are the things which are there. But in general, what you have to know as a layman is that uh, in a standard average hospital, an external beam radiotherapy, a normal radiotherapy, is the one which is offered, along with hormones in high grade disease. So in metastasis, the cancer which so far I have spoken about cancer which are locally localized, or local, it has just locally invaded, not gone out of the prostate. So if it's well within the prostate cancer, sorry, in the prostate, the options of treatment are: one, active surveillance in case of low grade disease; surgery in case of any grade disease, radiotherapy in case of any grade disease, as well as locally advanced disease. So radiotherapy, even local, it has spread a little bit outside the prostate, still radiotherapy can cover that area and kill the cancer cells. The cancer which has invaded the locally into blood vessels and traveled all the way through the body to bones, especially vertebra, which the backbone, which is the commonest site of spread. In that we call it metastatic disease. Metastatic disease, the problem is that once a person have a metastatic disease, the average life expectancy is around 3 to 5 years. So the prostate cancer grows by male hormone called testosterone. So the only way we can curb this metastatic disease, we can't remove the disease because it's many places. We can't go ahead and remove small spots in throughout the body. So the only way is we have to cut the feeding thing, which is male hormone. The ideal and the best way of doing or removing the hormone or male hormone is removing the site which is produced, which is the testis. But this is uh, traumatic for most men, as men will understand here, that removing a testis is psychologically traumatic. So even though we offer this treatment, most of the patients do not like it. So the alternate option is to do give some medication to suppress the hormones testosterone in the body. So these are usually given as either as tablets or injection, which can be given monthly or 3 monthly. What is the problem with this injection? Irrespective of whatever we do, once we start this injection, the prostate cancer cells become independent of this injection within an year or two, and they will start growing. Even if the hormones are not there, they will start to grow their own manner. So when patients with metastatic disease come to us, we tell them, okay, now it has gone to the rest of the body. The only thing we can do is it it can control it by giving you some hormone suppressing medication. But the problem is that in a year or two, you're going to come back with uh, the medicine is no more effective, so that we can go ahead with other modalities of treatment. So why it's important, imagine a 75-year-old man coming with a bone metastatic disease, and he's having multiple other problems like heart problem, which he's expected to die in another less than 5 years, or he's having another cancer, he's going to live another 2 years. Is there a point in giving these hormones? No, because this without these hormones also he may die only after 5 years, 10 years time. With hormones, again in 2 years time it becomes hormone independent, and even it can go worse. So in patients who have good life expectancy more than 10 years, these hormones can give benefit. Others have comorbidities, other problems, and shorter lifespan. This is hardly going to help. Or alternatively, we can tell them, let's not do any hormones suppression now. We will wait and see. If your cancer is spreading more and more, we will start the treatment at some point of time, and then when it gets controlled, we can stop it and again reach us, so that we can prolong your the independent stage, reaching the independent stage by changing the pattern of the hormone suppressing agents. So these are various manner by which we treat the metastatic cancer patients. uh, uh, these are the newer trends in the newer last 5-10 years in patients, young healthy patients coming with metastatic disease. Along with these hormones, we consider chemotherapy, which is just like the chemotherapy give for any other cancers, which show good benefit and survival. Very rarely we use it for some patients who are palliative. For example, patients having severe symptoms, we just need to cure his pain symptoms. We can start them on chemotherapy just to control the disease. So the main role of chemotherapy at this point is patients coming with metastatic disease. That means the cancer has gone into the bones, but young and fit who can tolerate the chemotherapy, uh, he will have good benefit from this the process. There are a lot of newer treatment options which has popped up in the last 5-10 years. Some newer hormone agents. You might have some of you who might have come in touch with prostate cancer patients. You might have heard about some treatments like abiraterone, enzalutamide, apalutamide. Sorry, if you don't know, I'm just telling you the names. For some of you it may be familiar, that's why I'm telling you. uh, and some radio pharmaceutical agents, which means that these are injections which given, it go to the specific side cancer cells in the bone and kill that cancer cells in the bone. But again, with the study or available information, these are only given to some selected patients who are having bone pain, or who are having no response to other treatments. These are not given as a routine treatment in NHS. In patients having hormone treatment, chemotherapy, all sort of these kind of newer agents, the side effect of these medications are bone loss, because just like menopause, we are creating an andropause, or hormone suppression in men. The bone can get weaker and weaker. So these patients who bones have problem may need support by special medications called bisphosphonates. And or most of these patients will be having vitamin D supplementation, calcium supplementation throughout their life. All these patients are also recommended to have good uh, exercise to maintain good health. All these hormones can cause specific side effects, as I mentioned, like andropause. Some patients cause flushing. Some patients may complain about again erection issues. We specifically deal with the problem by specific modifications accordingly. I mean, this is in general about prostate cancer. I think if you are happy, you can go ahead with the questions.
Can I just ask one question?
Yeah.
I think everything is explained very nicely, which quite a few things which we have learned, which is quite good. One thing which is causing some concern is that what is the purpose of prostate? Is it just holding the urinary tube?
I'm extremely sorry. Whether if I've not included in that, I didn't tell you about that. So prostate is a gland which produces around 30% of the semen. The semen, 30% of the fluid is come from prostate, and this the fluid makes the semen liquefy when in the lady's in the womb, so that it can travel all the way to ovary, and the sperm can move, swim, and cause the fertilization. So imagine the prostate was not there, uh, by God, this prostate was not there, the semen would have been like a creamy, a kind of creamy liquid which will never move, and the sperms cannot swim, and the fertilization will never happen. That is the role of prostate in the body.
Thank you very much. It's very so. That's why prostate gland is very, very important to look after.
Any more questions, anyone? Because with the chat, I think we've had some more one question so far. If you have any questions, do ask the doctor. Well, it's not a personal question, but generic questions you can ask. Dr. Pala will hopefully able to answer. There's a question originally from Madhuben. The question around
Yeah.
is the
I
treatment
just
of
wanted
sorry.
to know the pelvic floor exercise. If the only symptoms are frequency, and frequency increase in frequency, would pelvic floor exercise help?
So can you hear me now?
Yes.
So see, this is the bladder and this is the prostate. This is the pay which you pass water. There are two reasons why you can have frequency. One, the bladder is making unnecessary movement, which is called overactive bladder. In that case, pelvic floor muscles won't help you. Pelvic floor muscles are here, it won't help you. So overactive bladder have specific treatment like medical treatment, or bladder retraining exercises. You hold urine more to distend the bladder more over the period of time. The bladder will distend and try to hold more capacity. It's called bladder retraining, but not pelvic floor exercises. Number two, if the patient is have a benign prostate enlargement, like here, the patients tend to retain urine. When you retain urine, the capacity goes down, so you tend to go more frequently. So if a man with frequency, we have to do all these specific investigations to find out why he's having this frequency. And so pelvic floor exercises again is not a treatment for that.
One more question for you. Some patients have experienced burning sensation while passing urine. Is that part of the problem with the prostate?
In a man, burning sensation of the prostate, a burning sensation of the urine, or we call it dysuria. This can be due to inflammation, enlargement, prostate cancer. It can be anything in the urinary tract. It can be unrelated to prostate and related to the tube. It can be related to the bladder infection. But since we don't have a screening program, we explain the patient with any such symptoms to visit a doctor and do the investigation. And if you are of a younger age group, we just suspect infection. If you are, say, 50, 60 plus, the doctor will do further examination along with urine test to make sure that we are not suspecting any nasty elements.
Yeah, thank you.
There's a question from Dr. Seema Datta regarding the treatment of cancer prostate. Could you ask that question, Dr. Seema?
My question is the treatment for CA prostate, regardless of the age, for mild one, is wait and watch? You said that 98% people survive 10 years. So if you say that the early diagnosis was at 70 and you are happy to stay till 80, but if you're diagnosed at 50, you may want some treatment, because even survival till 60 is probably not acceptable to me. It's not me, means to a patient. So just a quick, I don't know, it was just a little query in my mind that does the age matter for wait and watch, or you would say, okay, just wait and watch?
Yeah. So a very good question. But essentially the wrong element in the question is that it's not watch and wait. It's called active surveillance.
Sorry, yeah, no, okay, yes, active surveillance. Yes, I do apologize.
Yeah, no, there's a big difference. Why it is different?
Yes,
Yeah,
yes.
why it's different. Imagine you have a 50-year-old man with a very low grade disease.
Yes.
And we offer all these options to him. Mm-hmm. And if he says that I don't want to take any risk of complications with the treatment, then he can have active surveillance, which means that he will be closely monitored by having regular PSA examination, prostate examination, and yearly MRI scan. At any point of time, if you think that his stage is changing, we offer him active treatment.
Right.
But in a 70-year-old man, it's different picture, because by the time we do all these things, he might reach his 80s.
Yes.
So when we say all these options are open to them, it doesn't mean that he is a candidate only to have active surveillance. He can have active surveillance as well in a low-grade disease, because even if his disease changes and become aggressive, we will pick it up early and we do offer the appropriate radical treatment or active treatment.
Okay, I mean, I'm not saying that, I'm not asking you to really make it black and white, but if the patient wants, like a young patient, 54-year-old, wants treatment for low cancer and happy to accept the complication, would you be able to offer one?
100%.
Okay.
We have to offer him, because it's all personal choice. Some patients psychologically will feel better when they ensure that the cancer is out of their body, and they are not bothered by erectile dysfunction or urinary incontinence, but they are psychologically they're happy.
That's exactly, because I know someone who's probably 57.
Yeah.
And he's been offered active surveillance, but I think psychologically he's not able to accept that he has so-called cancer in his body. Yeah. And he feels that he's like, I don't know, it's like a explosion, you know, he
Yeah,
always
yeah.
feels it's like a time bomb on which is clicking, and he's not able, he's now more mentally ill than he was, or he
Yeah.
is, because of the CA prostate.
So he can talk to his doctor and change his mind anytime.
Anytime.
Yeah, today he may opt for active surveillance, and tomorrow he can come and tell me that I want radical treatment. We have supposed to offer him. So absolutely no problem. It's
Right.
patient
Thank you.
choice,
No,
basically.
I appreciate that.
Yeah,
Thank you. Thank you.
no
Thank you,
problem. Thank
Dr.
you.
Seema. Thank you for that question. I've got another question in the chat from Bhagwan-ji. I've been told there's a new therapy for prostate which uses steam to reduce the size of the prostate. Is surgery better than having steam therapy? And what are the success rates of the two options?
Okay, so this is a question not related to prostate cancer, as you may know. This is related to a benign prostate enlargement. As I told you, the difference between these two are, one is a normal cell increasing in number, other one is an abnormal cell. So steam therapy or any or other therapy is not a treatment for prostate cancer. The first thing you have to keep in mind. Second thing, for benign prostate enlargement, the standard treatment is called TURP, or we go in with the camera and chip out the prostate and make the channel wide. Are you able to, do you see my,
Yeah,
yeah, okay.
I can.
So we make the channel wide and patient can pass urine comfortably. That is called TURP. As an alternate modality, a lot of treatment options have come up, like Eurolift, which is placing a clip here to widen the channel, or injecting a steam called Resume. These all modalities have only 5-year data. So we still can't offer information about what is going to happen after 5 years or 10 years time. In short term, patient is having good response, and this good response in selected number of patients where the prostate size is not too big, and patient is ready to accept if it fails. A patient is ready to accept the burning sensation after the procedure, which is common with this steam therapy. So there are a lot of factors which relate to this particular procedure and all the newer modalities, which we can't answer. But the one we have told you, which is a standard treatment called TURP, is been studied over last 50 years. So we have long strong data to tell what are the plus, what are the minus. So we more confidently offer them these kind of treatment. The in larger prostate, other than all these things I have told you, is a laser treatment which is showing the best. For example, the prostate size is grossly enlarged, very big prostate. We can't do any of these smaller modalities. A laser enucleating, peeling off like an orange peeled off from the thing, similar to that we use with a laser, we peel off. It's called holmium laser enucleation of prostate. That is the best modality so far, what we know.
What we can do to keep our prostate in a healthy conditions? Is there any exercise or any eating habits or our activity, exercise, anything which we can do to maintain a good health of the prostate?
So far we don't know, we don't have any evidence to clearly say, but since Asian population has less chance of getting prostate cancer, and Japanese population have less chance of getting prostate cancer, and when an American man moved to Japan, the chance of prostate cancer also gone down with. So we assume that there's some geographic dietary factors that may play, we don't know exactly, that may play in forming these problems with the prostate. So a healthy, balanced, maybe non-veg diet, I don't know, maybe that kind of Asian diet is better for prostate than Western diet. I assume there's no clear-cut data to support these things, but these are assumptions we extrapolate from the information we have. In generally, any patient who asks us, I say a balanced, healthy diet.
That's great. Thank you. We'll stop there, Dr. Pillai, because we've got so many questions answered already. We're running out of time, would you believe, already? That's been so informative and so well presented, Dr. Pillai. Thank you for that, and all for the questions we've had so far.